Welcome everyone to today's webinar, Social Determinants of Health, COVID-19 Impact Disparities. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. With that, I am pleased to welcome today's speakers. Shefali Ray is the Senior Networks Director at Vizient, and Carol Kopaski is the Associate Principal at SG2. Shefali and Carol, thank you for being here today. And Shefali, I'll now turn the floor over to you.
Thanks so much, Ayla, and thanks to you and the Becker's team for giving Carol and me the opportunity to present to your audience today. Before we dive into our content, we did want to take a moment to just share a brief overview with all of you about the organizations that we work for. Vizient is the largest member-driven healthcare performance improvement company in the country. We work with thousands of members, including academic medical centers, pediatric facilities, community hospitals, integrated health delivery networks, and non-acute healthcare providers. And we help our members achieve cost, quality, and market performance by providing access to data-driven solutions, strategic and operational collaboratives, and industry-leading subject matter experts. Carol, do you want to tell us a little bit more about SG2?
Sure thing. Thanks, Shefali. SG2 is a Vizient company that's also the healthcare industry's leading healthcare analytics, intelligence, and advisory firm, specializing in health system strategy and future insights for over 20 years. We focus on leveraging data insights partnered with top industry experts to help our members make smart growth decisions for today and tomorrow. And we're very excited today to share a little bit about what our two experts have been researching on COVID-19's impact on health equity in healthcare delivery. We wanted to cover four key topics. First, taking a brief look at the landscape itself to understand the impact of COVID-19 and how it has exacerbated disparities among minority groups. Then we will take a little pause to talk about how health systems can determine their role in social determinants of health and social needs initiatives, with examples of initiatives from prior to and after the COVID-19 pandemic. We'll then talk about how we can take action today and looking at different pieces of your organizational structure, as well as your data insights, both internally and externally, and those key partnerships to help you align with your community needs, so how you can respond to that growing need in the marketplace today. And then finally, we'll close with a few Vizient resources that are available publicly for all of you to start that journey in understanding your health system's response to COVID-19 and your community's needs. But before we dive too deeply into the content today, we wanted to make sure we level set a little bit about the social determinants of health. And I'm sure many of you on the line appreciate that when we consider an individual's health outcomes, there are a myriad of factors that will influence ultimately what occurs for that individual patient. So not only is a patient's health outcome influenced by their age, their genetics, and their individual lifestyle choices, but much of their health outcome will depend on their social and community networks and the social determinants of health that influence their community at large. So things like how safe is their environment, what does the employment landscape look like, is there safe and appropriate quantities of food and water available, and what is that educational attainment available for patients in this community. All of these factors work together in concert to promote health outcomes at both the individual and the community level. And we thought it was important to emphasize that there are going to be those differences, not only when we're thinking about how to best help an individual's health outcome, but also how can we support our communities as a whole. And we know that that language is so important when we're trying to communicate and develop these programs. So we wanted to ensure that we had these definitions really transparent up front. When we think about those programs that impact the underlying community-wide conditions, those are going to be initiatives that are targeting the social determinants of health, so those broader community wide conditions that will shape the broad economic, social, and political forces that impact our community's health outcomes. We'll also be talking about some programs that address social needs. So these are immediate unmet needs of individuals that increase the likelihood of a poor health outcome. And then finally, we will start today by talking a little bit about some of those clinical manifestations of social determinants of health. These are those downstream impacts of community conditions on an individual's health and on healthcare delivery that most of our health systems feel most painfully in their healthcare systems today. So these would be things like excessive ED visits or long inpatient stays. And so we thought it was important to level set on the language at the beginning because as we heard from the VP of the Value Initiative, as an industry, we want to be sure that we're at a place where we're using common language to drive consistent change. Now, prior to the COVID-19 pandemic, we had even begun to see additional attention being placed on the social determinants of health by healthcare systems. And this was driven by several underlying community pressures as well as health system pressures. On the community level, we had begun to see the significant rise in comorbidities and chronic conditions in the adult population, both for physical conditions and mental health conditions, as well as a significant rise in income inequality, as well as a looming crisis in savings for the increasingly aging population in the US. So we know that these community pressures are contributing to a growing need at the individual and community level for healthcare services that take into account some of these social determinants. On the health system side, we're also facing significant pressures to address more of these social needs and social determinants for our patients and communities. We see increasing emphasis on contracts that have downside risk or risk-based payment. We're seeing a rise in the proportion of providers that are having government pay be their primary income source. And we're also beginning to hear in certain markets some pressures about the percentage of revenue that has really contributed to charity care. So while we have seen prior to the pandemic significant revenue increases, especially for nonprofit health systems in recent years, we saw charity care begin to fall during that same period. So we do expect both external and internal pressures to drive the need for health systems to respond to these social needs and social determinants of health in their community. And we do expect this to certainly be continuing in light of the recent pandemic. Isn't that right, Shivali?
Yeah, that's absolutely right, Carol. And as you described, social determinants of health were sort of having a moment, if you will, before COVID. And now in the context of COVID, they've become more relevant than ever. In fact, over the last 9 months, we've seen how significant the effects have been on our country's most vulnerable populations. We've seen differences in the infection rate and in the mortality rate. We've seen differences in who's getting the virus, who's getting really, really sick from it, and in fact, who's dying from it. And we've also seen the economic impact. The pandemic has really amplified existing disparities. It's created more significant gaps in things like unemployment, which has resulted in increases in homelessness and food insecurity. And while the individuals that may be impacted by these specific disparities may not be hospitalized today because of COVID, due to those clinical manifestations that Carol described, there's a really high likelihood that the health system will be involved and play a role in addressing the downstream impact that they may have on the future. One of the leaders that Carol and I have worked with, that Vivian Nesh-Chitu has worked with over time, Dr. David Ansel from Rush University Medical Center here in Chicago. He's the Senior Vice President for Community Health Equity there. He has a really powerful quote that we often like to refer to, which is, society's unfinished problems usually end up on the front door of the hospital, and oftentimes that front door is the emergency department. So when we look at everything that's happening around us and the data that's now becoming available, we're finding that many of the populations that are affected by these disparities are people of color. We have started working more closely with a number of organizations across the country who focus on caring for vulnerable populations in their community. And one of these members, Dr. Chris Purnell from University Hospitals in New Jersey, points out that COVID is actually not the only pandemic that our country is currently experiencing. And she shared a quote with us recently that we included here that I think is really relevant to what we're talking about today. This second pandemic that she refers to, which was, frankly, born out of systemic racism, is also a public health crisis, and it's significantly devastating Black and Latinx communities. So let's take a moment to look at the data around this. You know, we've seen over the last 9 months that the virus impacts people of color very differently. In fact, on the CDC website, they note that compared to whites and non-Hispanic persons, Blacks are actually 3.5 times more likely to be hospitalized for COVID and almost 3 times more likely to die from it. And Hispanics are 4 times more likely to be hospitalized than whites. And, you know, Vizient is actually seeing similar trends in the patients that we care for by our own member organizations. Our analytics team used data from the clinical database, or CDB that we like to call for short, to assess the impact that COVID has on race and ethnicity. So by way of background, the CDB is an analytics platform for patient outcomes data. That tool provides metrics on things such as mortality, length of stay. We provide complication and readmission rates, and our members use all of this data to compare themselves to their peers and to work on performance improvement opportunities. So our analytics team at Vizient took that data from the CDB and they stratified the inpatient data by race and ethnicity for more than 550 hospitals from the time period of April 2020 through November of 2020. And just to orient you a little bit to the data before I jump into the graph here, they took that data and they stratified it by 3 race categories: white, Black, and Asian. And then each race group, they excluded the Hispanic origin ethnicity to call that out as a separate cohort. So we ended up with 4 cohorts: white, Black, Hispanic, and Asian. And for the purposes of this analysis, any patients whose race was identified as either unknown, declined, or other, we grouped that into a 4th category, the other category. So in the graph here, each of those race and ethnicity categories are categorized as a color. And then moving along the x-axis, what we did was have a comparative data set relative to the U.S. population. And we used the census data from the 2018 American Community Survey for that purpose. So when we look along the x-axis, if you take the first data point for U.S. population, that is, again, taking that ACS data, the American Community Survey data, and you can see there that 60% of the U.S. population is considered white. When you look towards the second data point on the x-axis, we compare that against our Vizient data from the CDB data. So of the 2019 patients that those 550 hospitals saw, you can see that 61% of those patients were white. The rest of the data points along the x-axis take a look at the severity of COVID-19, so the COVID-19 diagnoses, hospitalizations, ICU stays, and mortality. So a couple of things to point out. So I mentioned that the population, we looked at the population characteristics of the Vizient data relative to the whole U.S. population, and they're actually really similar. So I mentioned the U.S. population for whites relative to the Vizient population. But similar to that, when we look at the kind of dark orange part of the graph, you can see that the Black population as a whole is represented at about 12%, and for our Vizient members, it was around 16%. Hispanics there in teal, that population as a whole is represented at 18%, and for our members, it's 11%. Now, as we shift to the right in the graph, you can look at the rate of COVID diagnoses and COVID-related deaths by race. And while we see that white patients make up about 38% of the COVID diagnoses, Black and Hispanic patients together make up about 50% of those diagnoses. Hospitalizations, ICU stays, and deaths from COVID as we move along the right side of the spectrum of the graph have a similar trend. And sadly, as you can see that band actually widen for Blacks and Hispanics as the severity levels increase. So we took this analysis a step further and sliced the data by age. And, you know, I think we've seen a number of data points across the country, and we know that age is certainly a strong predictor of COVID-19 outcomes. But what's interesting is when you look at age data alone, without the context of race and ethnicity, you may not necessarily get a complete picture. So what we did was take that Vizient data and we overlaid race and ethnicity with age. And we can see here that Black and Hispanic patients make up a higher percent of COVID diagnoses in that 20 to 60 age range, whereas for white patients, that occurs actually at a higher rate above the age of 60. So the point here is that evaluating the data in this manner can really help your organization as well as our public health departments create more population-specific tailored strategies and approaches that could be used for things like education, prevention, testing, and treatment. The data could also be used to inform strategies of how you may want to invest in addressing specific social disparities. Carol, do you want to tell us a little bit more about those investment strategies?
Absolutely, and I do want to take a moment to pause and acknowledge that we've certainly just covered a lot of different data and a lot of different ways of thinking about the challenges that are facing our different communities throughout the entire United States. And it's going to be really critical as health systems look to respond to this complex, really challenging landscape, to take a framework to help think through what are those programs that we can work with to address clinical manifestations, how can we help address the social needs within our community, and then are there those steps we can take to really address the underlying social determinants that are impacting our communities at large. And so we offer this framework to help health systems begin to organize their thinking and what those responses could look like. And so we'll take a moment just to go through what this framework describes. On the left-hand side of the slide, you see we have a category called address. And these are those initiatives that are designed to support discrete interventions that address the clinical manifestation of social determinants of health. So thinking here about a health system that is noticing an increase in ED utilization among a certain segment of their population. They may be seeing this population coming in as high utilizers, coming in multiple times a day or many times a quarter, and recognizing that this is a burden both for the patient who's receiving this care in an inappropriate channel, as well as for the health system itself from the cost perspective. And so when we develop those interventions to target the immediate clinical needs of a given patient population, this is how we can begin to address some of those clinical manifestations of social determinants of health. The next step towards the right of the slide, we categorize as those aligned. So this is where when we begin to see health systems reach out and work with their community partners, be that government agencies, community benefits organizations, FQHEs, and other key stakeholders across the community, to leverage data and insight across all of those different partners to tackle those needs beyond the immediate needs in the medical setting. So here we can start to be a little bit more proactive. We can think upstream about those needs that those patients are having before they reach our health system doors. And we're also getting more comfortable sharing and interpreting data that's a more complete data set for our health systems to begin to respond and prepare for longer term interventions as well. Finally, we see fewer health systems today, but we're beginning to see more excitement and movement in this direction towards considering the health system an anchor in the community. And so here we're describing these health systems in a way that they can impact the community beyond just the clinical care that they provide at a high level across their community, but also thinking of that hospital and health system as a bigger player in the community at large. So thinking of what role can we play as employers, as purchasers, as investors, and as advocates for members of our community, and how can we leverage the kind of clout, if you will, of the health system to impact that community health and improve some of those underlying determinants that influence our community's needs. So we've used this framework for a little while now, and prior to the pandemic, we had begun to see that there was some really exciting change that organizations were undertaking across all three of these different frameworks to begin to address not only the clinical manifestations that are critical for those patients experiencing high levels of utilization, as well as for those organizations that are starting to think long-term and more systemic changes. So I wanted to share 3 examples of how organizations had leaned in prior to the pandemic, and I think you'll see a couple of common themes across these different examples. So to begin, we wanted to share an example from the Queens Medical Center in Hawaii, who are facing a significant homelessness challenge within the state. And what they did is they identified for those super utilizers, those high utilizers of ED services within their health system, they developed a post-discharge intervention that included intensive care navigation to help manage that population and reduce that ED utilization by ensuring that they had access to either housing or additional services, and allowed them to kind of reduce that overall utilization from a health system perspective, so to reduce some of that cost associated with that population, but also lead to better health outcomes for that patient population as well. So Here, really that focuses on how can we, once we've identified that patient within our health system, how can we work with them to help improve their health outcomes post-discharge and ensure that they're connected to all of the clinical care that they need, whether that's primary care or specialty care, to help prevent that subsequent ED admission. Moving into that aligned category, UK Healthcare also identified a significant challenge among their homeless population and took the communication and collaboration to the next level. So here they worked with partners across their community, including the local FQHC, Care Navigator organization, as well as first responders within the community to identify what are those support structures that are needed to help support their vulnerable patient population and provide services upstream to help reduce some of that utilization. Excuse me. And what they were able to find is that by coming together as a collaborative, meeting regularly and sharing data, they actually did form a business associate agreement that was put in place to help foster that communication in a more fast and consistent way. They were able to make a real impact on that high utilizing population, as well as build those strong partnerships across 4 key groups within the community to allow for longer term tracking and influencing of that community. And Shefali, I know that you've been working with them very closely. Anything you wanted to add to that program?
I just want to share just one insight that I know we'll get to a little bit later. And I always chuckle when I think about the colleague I work with there who focuses on this because it's so important. And that is with any of these initiatives, and in particular this one, what they did was really look at measuring any and all data that they had available to them to demonstrate the impact that the program had for the community as well as for the health system. It was an innovative way of thinking about how to address these needs. And so they really tapped into the data that was available to help to support the expansion of that program more broadly.
And I love the quote that we pulled out of that conversation, that these partnerships are like marriages. They require time, dedication, and understanding. And I think that this type of an initiative really demonstrates the importance of that partnership and cultivating that relationship as a long-term standing relationship to help our patients in the community. The last example we want to share is from Rush University Health System in Chicago, Illinois. And they developed an anchor strategy to focus on some of those underlying social determinants of health. And what was really creative about the Rush response was that they leveraged their community health needs assessment, so that regulatory requirement that nonprofit health systems have to complete every 3 years. They leveraged the insights that they gained from completing that process to develop this comprehensive strategy and response to help address the significant health disparities on the west side of Chicago. So they took that insight that they gained and developed a multi-pronged plan that included not only clinical care, but how can we economically develop the west side of Chicago, identifying opportunities to promote career planning, hiring, as well as supporting local businesses in the community, to help address some of those underlying needs within the community and help to promote the health and reduce some of the health disparities between the west side of Chicago and downtown Chicago. So really changing the mindset of what a health system can and could be for their community and becoming that community anchor to try to promote long-term enduring change for the communities on the west side of Chicago. And when we think about what are those investment strategies and how are health systems continuing to respond prior to the pandemic, we did see a lot of financial commitments to support this type of work within the U.S. health system prior to the pandemic. And you can see, looking at the different investments that were publicly reported here, housing far and away stands out as one of those elements where we see a lot of folks looking to work today. But we do think there is additional opportunity for health systems to rethink their perspective, the way that Rush really took the lead there, and think about themselves not only as providers of that healthcare, but think of themselves as purchasers. They purchase quite a few goods and services throughout the community. How can we make decisions about those purchasing agreements that favor and help develop our community? How can we act as employers to promote reduce unemployment rates in our community, but also focus on local hiring and developing our community's workforce? How can we rethink our investments to better support our communities as a whole? And how can we consider thinking about our community benefit spending to not only include charity care, but potentially support other benefit opportunities throughout the community? So a lot of work that had been done prior to the pandemic, a lot of commitments made to invest in these types of programs, but certainly a lot of opportunity to continue to respond. And we did see a lot of really interesting responses as the COVID-19 pandemic got off the ground to help as our health systems solve the exacerbated challenges that their communities were facing. And so Shefali, do you want to share a little bit about what are some of those more recent examples that our health systems have undertaken during the pandemic?
Yeah, sure. Thanks, Carol. You know, the health system's role in public health has certainly drastically changed in light of COVID-19. You know, during the initial surge, health systems and other stakeholders certainly partnered with communities to help flatten the curve, especially among the most vulnerable populations in the communities. But as we've cycled through more surges, we see that health systems are not only continuing this effort, but they're also expanding the work with a greater number of stakeholders. And they're looking to offer programs in different ways to help their communities with addressing specific needs. So here are just a few examples that have been stood up during the pandemic. The first is VCU Health. So VCU Health is a comprehensive academic medical center and health system in Central Virginia. When the pandemic hit, they integrated multidisciplinary action teams to support specific areas related to COVID. And one of these action teams was charged with evaluating the educational resources that were being shared with the African American, Latinx, and senior populations. They had discovered through this work that the literacy levels weren't appropriate and that even some of the information that was being given to Spanish-speaking patients wasn't really helpful because of the multiple dialects of Spanish that were being spoken by the Latinx populations in the surrounding areas. So VCU created a specific work group that focused on Latinx education, and this group brought together representatives from the local health department as well as from organizations in the community that were serving the Latinx population. And together, they developed communication materials that included a lot of infographics so that regardless of the dialect and literacy levels, people could look at pictures that could help them understand the importance of things like hand washing and wearing a mask. You know, another interesting discovery that came out of these discussions was that the group realized that there was a need to talk to the local businesses. They had uncovered through these discussions that there was a great deal of misinformation that was being passed along by local employers. One of the FQHCs that the system worked with was actually seeing a lot of COVID positive construction workers who were working on various capital projects in the area. And the FQHC had reached out to VCU to see if they could talk with the contractors. But what they found through this collaboration was that they actually needed to have a broader conversation with employers because they were misinterpreting those CDC guidelines. So VCU partnered with the Virginia Chamber of Commerce and the Virginia Hispanic Chamber to develop a series of educational webinars focused on the problems that the employees were having with interpreting the CDC guidelines. And the webinars included presentations by providers from VCU, from epidemiology staff at the local health department, as well as the FQHC. So together, they were able to create information that the businesses could use to educate their employees. The second example is from UAB Medicine in Birmingham, Alabama. So UAB is a statewide network of owned and managed hospitals that serve a number of the underserved areas and the rural areas across the state. And over the last 6 months, UAB has partnered with 2 different nursing homes to facilitate the care of positive COVID-19 patients. You know, many of the nursing homes in Alabama, similar to other parts of the country, did not initially have the capacity to isolate patients or the manpower to care for them in a safe way. And so they had developed this collaborative model where UAB would set up dedicated units with the local nursing homes and with short-term rehabilitation centers to care for asymptomatic or mildly symptomatic nursing home residents after their extended COVID illness in the hospital. And the result of this was that the units ended up easing pressure on the hospitals by freeing up the beds for more acute patients, both COVID and non-COVID acute patients. And then the last example is Kaiser Permanente in California. Kaiser is one of the nation's leading healthcare providers and not-for-profit health plans. They have a tremendous commitment to the Anchor mission, and through this work, they're actually leveraging their business practices to strengthen their local communities. The latest example of this is actually Kaiser dedicating $63 million to support contact tracing in California. It involves partnering with a local organization out of Oakland called the Public Health Institute, where together they will hire and train 500 full-time workers as contact tracers. What's great about this is that these individuals are being pulled from communities of color that have been hit the hardest by COVID. And these 500 individuals are able to contact up to 5,500 people a day. This investment is actually going above and beyond supporting the workers during this immediate need. They're actually using this funding to also provide job training and skills to guide these workers on career paths after this immediate initiative ends. So, I think what's really great about these examples is that they show how this work can have such long-standing impact on the community. And what I'd like to do is actually take us back to the example that Carol shared earlier around UK Healthcare's collaboration with their Lexington community partners and share a video with all of you that I think does a really nice job of depicting how cross-collaboration can positively impact a community.
Homeless individuals tend to use our emergency department as a safety net. We actually had 2 individuals over the past 12 months that made more than 1,000 visits to our emergency department.
And then when the COVID pandemic arose, our whole community became very concerned about the safety of those living in shelters or receiving services from providers throughout the city.
So as a community, we really had to stop and look at that and think, how do we help these individuals that need to self-quarantine actually do that and be successful?
I had the chills, I had a slight fever, I was nauseous, and I had a cough.
We certainly do not want to leave them on the street where if they're positive, they're going to infect others.
We've come up with our coalition some unique solutions and countermeasures to help quarantine them while they're waiting for the results of their test.
Bluegrass Care Navigators has been an incredible community partner previously, and they met this challenge from the very beginning.
When a homeless individual is PUI or confirmed to have COVID, we transfer them to a hotel room, and there we provide them with the meals that they need to have in their room.
It's the main reason that as a community we've had such a limited amount of spread of the virus among our homeless population.
The hotel does not provide any services in the room while the individual's there, and then we work with a cleaning company to come in and clean and disinfect the rooms.
I was told I had to stay in my room until I got the test results back to prevent maybe spreading of the virus.
One of the real benefits of this program is that it is very low cost. The hotel room contracts we have are in the $55 to $65 range. Transport is cheap. It's avoiding the emergency room. It's allowing us to provide the care very quickly and with minimal disruption.
This partnership with Bluegrass Care Navigators has really been, I think, one of the critical success factors for why we've been able to affect the homeless population in this way.
We have only had 3 confirmed cases since March 13th in our homeless population.
I appreciate it more than anyone could imagine, because I'd want someone doing that for another member of my family as well. And I'm truly blessed to have been given this opportunity.
All right, thanks. Thanks to UK Bluegrass Navigators and the City of Lexington for all of their work in managing the spread of the disease and supporting the homeless population in their community. So, where do we go from here? Well, it's important to note that external pressures will continue to push health systems to define their role in addressing social disparities. It's really likely that as we pull out of this pandemic, policymakers will continue to be faced with increased pressures to cut spending due to stalled business activities. So in many cases, these cuts will likely have a downstream impact on our hospitals. At the same time, the number of families that need public assistance is growing. We've seen that individuals are having a hard time meeting basic social needs like food and housing. And the community-based organizations that provide these services are seeing such high demand currently. Many of them, like food banks, are left beyond their capacity. And finally, payers are also playing a bigger role in this space. They're increasing their involvement in addressing social needs, and many of them are contracting directly with community-based organizations. In fact, we've been hearing that in some of these cases, payers are actually circumventing the health system altogether. And this can have unintended negative consequences because many health systems are screening for social needs and connecting patients with community-based organizations. We're hearing that when the hospital is not involved in these conversations, the result can actually be a disjointed effort and create a lot of confusion for patients. So that's a lot to digest. Let's just take a moment to kind of unpack, what does this all mean? Well, if you were to look within your own organization, it's highly likely that you are going to find a number of examples of how your hospital or health system is looking to address social needs and disparities. All not-for-profit hospitals, for example, have to complete a community health needs assessment. So you may be doing some effort related to that, or maybe your organization is pursuing some population health initiatives, or maybe you're standing up some pilot projects in some of your clinics or in the emergency department. But in reality, oftentimes these efforts can be disjointed or they can take place in silos. So one of the key questions that we ask system leaders is, are you doing enough? And take some time to really evaluate how you can make community health a foundational part of your organization, not necessarily just in terms of your mission, but in terms of all of the initiatives that are taking place at both the system level as well as down to the department level. So, with the release of the vaccine, hopefully we will be nearing the end of this pandemic. But one thing the situation has taught us is that disruption due to COVID-19 is certainly going to be long-lasting. And it'll be important for healthcare organizations to critically evaluate how they stabilize, adapt, and evolve themselves as they pull through this public health crisis. And we wanted to leave you with some approaches that our Vizient member chief strategy officers are taking as they look to evolve their role in cultivating community health and well-being as part of their strategic planning efforts. In addition to things like testing and other public health related support like contact tracing and testing, they're looking at how to support utilization and adoption rates of virtual health, for example, or telemedicine across vulnerable populations. Some of our academic medical center members have shared with us that they're actually establishing community health and well-being as a fourth strategic pillar to their historically focused tripartite mission that includes clinical services, teaching, and research. And our members are exploring partnership opportunities with non-healthcare related industries like financial services or tech companies. And it's also worth noting that health systems are recognizing that they can actually be an advocate for change, given their size and their role in the community. We conducted a small survey of our members in September to assess where their organization was on the spectrum of addressing social determinants of health. Then pre-COVID, the majority of the organizations responded that they were more on the address side of the spectrum. They were doing a few things here and there to address those clinical manifestations. But since COVID, we've actually seen a larger number of them shift more towards the right. They're doing more things to align and actually get started on more anchor strategy type of work. So the key takeaway here is really that organizations should use this as an opportunity to seize the moment and most importantly assess how will they sustain these efforts post-pandemic. So Carol, tell us, where do you think organizations should start?
I think that there's really a couple of ways that organizations can get started in this work. And I think especially when we're looking to make that transition from address to align, or even some of those organizations who may still be in the pilot phases or early on in that address kind of work. There are three key areas where we've identified as good places to start when we're beginning to think about this work and identify the most meaningful interventions for our community. And they really boil down to some different forms of know thyself. So how can we assess our internal organizational structure and ensure that the way that we're organized helps to align incentives and ensure that we have a structure that supports this type of work and initiatives across our health system. Certainly leveraging existing data and scale the use of that data. So we'll talk a little bit about how health systems today collect a lot of different data that they may not be utilizing as effectively. Things like leveraging your CHNA, data from your own EHR, and then there are often really robust publicly available data sets that can help supplement that work that you're doing. And then finally, identifying those opportunities for collaboration and partnerships. I think just about every example that we've covered so far included a partnership of some form, and those partnerships really are the linchpin to getting these programs off the ground and sustainable over the long term. So we'll talk a little bit in that last section about some partnerships that we saw arise during COVID that lended themselves well to quick responses for those communities, and what are those features that can help other organizations really begin that pivot towards sustainable social determinants of health initiatives. So, Shefali, do you want to share a really fantastic example about developing an organizational structure to respond to the pandemic?
Yeah, sure, thanks. You know, I actually want to circle back to VCU Health because I think they created a really great structure, or utilized an existing structure to support their patients during COVID. So, you know, in the example that I gave earlier, I had mentioned that VCU had stood up these integrated action teams to focus on specific population health needs. And what was great was that these action teams were actually formed out of an existing structure that the organization had put into place a couple of years ago. The infrastructure was built around the 4 groups that you can see on the slide that are shaded in green. So the research, innovation, patient services, and training and education. The goal of each work group was to ensure that the organization was looking at each of these 4 areas through a health equity lens. And so when the pandemic hit, they thought rather than stand up a whole separate infrastructure to support COVID patients, to actually stand up a dedicated group focused on COVID health disparities within this structure. So what they did was pull together an initial task force that looked at what their organization could do in collaboration with others in the community to specifically support 3 different patient populations: the African American population, Latinx population, and the senior population. And the task force included reps from the university, the health system, local health departments, and community-based organizations. And they created 3 action teams based on this feedback. One focused on education, one focused on community partners, and one focused on telehealth. The examples that I shared earlier came out of that education action team. So each action team defined its focus areas from feedback that they got from the community partners, but also from data. They, for example, when they saw that the unemployment rates in the areas were going up, they realized that the community members needed additional assistance, like applying for financial assistance or finding ways to get more supportive housing and food support. And the system realized that they couldn't take that on along with the other areas that they were focused on. So fortunately, through these collaborations with other organizations, they had learned that the mayor's office in Richmond had developed a coalition of organizations that was focusing on things like financial assistance, food access, and housing assistance for individuals who were out of work and in quarantine. So VCU was able to join that coalition as a participant, listen in on what those efforts were to help guide patients that they may see through the system, but they were able to then retain their focus on the areas that they had outlined through these action committees.
It's such a great example, and I love that idea of them being participants and part of that group, which is really that feature we see in the aligned group where health systems, they may be leading from behind, if you will, or they may be more of that collaborator and letting those who have expertise in different areas taking the lead and then really standing up in those areas where the health system has the most expertise. So thank you, Shefali. That's a fantastic example. And I'm going to share a little bit about how we can think about scaling data collection. So I know Shefali shared some really fascinating data from the Vizient clinical database earlier, but what's interesting is a lot of these types of data we can collect from our own internal data systems as well. And so when we think about what's that first step towards developing a data analytic approach to identify and support these social determinants of health initiatives, we're really encouraging folks to look within the data they have on hand already and ask themselves a couple of questions about how are we analyzing and sharing information even across our internal team. So are we sharing information between the folks that are conducting the community health needs assessment and the strategy teams? Are we sharing data between different sites across our health system, inpatient and outpatient, inpatient and outpatient participants? So how are we making sure that we have that effective use of data collection as well as sharing of information within our systems is a really good place to start. We also encourage folks to think about how are we collecting this type of information. Often when we're talking to those individual patients coming through our doors, asking certain questions with deep empathy can be really critical to get the important information that our clinicians need to know, but also that information that can help us identify real needs within the community at large. And that really does rely on training and working with our frontline medical staff to help them gain the appropriate tools to collect that information in an empathetic way. So we want to make sure that when we're collecting this information to be able to use, we really have that patient at the center and understand that the reason we're really doing this work day in, day out is to help that patient's life improve and become better. So those are some ways to think about on the internal side, how do we want to optimize our internal data capture, leveraging systems already in place and emphasizing empathetic data collection. We also want to ensure that we take that opportunity to incorporate out external data as well. And the community health needs assessments are, again, something that you have to do every 3 years anyway, and it does leverage oftentimes a lot of external information as well. So we encourage as a first step, using the work that you have to put in, that you are putting in already, and letting that inform what are some of those key data points that we need to be thinking about and monitoring over the long term. So how can we turn the CHNA into a living document where we're continually including information from outside data sources as well? And certainly looking to Rush again as that example, where the CHNA, it can be a checkbox or it can be something that you leverage to improve health through intentional strategies. And so we're encouraging all of our teams to think about the CHNA in a more strategic way as opposed to just a regulatory requirement. So we know that data is going to be important, how we're organized is going to be important. And finally, we want to come back to this idea of partnerships. And I think that the key takeaway that we want to emphasize here is that we want to be creative about who are those best partners to help our members of the community. And so we saw kind of two really key different examples that arose during the pandemic, and we wanted to highlight different features of each of them. And so Project Roomkey, I'm sure several of you are familiar with, was a project that was set up in the state of California, really driven by state, local, and federal governments in partnership with community-based organizations and health systems to provide hotel rooms and wraparound services for unhoused patients with COVID-19 or those individuals at high risk of contracting the disease. And so this is an example of really on the government side, working with those government officials as well as community-based organizations and health systems to create a broad geographic solution that addressed a larger population that had really significant needs in a very quick way. So I know we've talked in several instances about how we can help to house the homeless population as a response to COVID-19. And what's really key about a program like this is to ensure that all of the collaborators are on the same page and acting in concert. And similarly, I wanted to call attention to City Block Health. So this is a digital health platform that partners with different health plans in a risk-based contract model and community-based providers to manage a cohort of patients that they refer to as their members and ensure that those patients are kind of intensively cared for in an effort to promote health for those patients, especially who are on Medicaid or government pay plans. And what was really important about that digital platform and what it enabled City Block Health to do in response to the pandemic was to develop a data-driven adaptable model to help them identify their highest risk members. And so this model is actually published in the New England Journal of Medicine Catalyst publication. And so what the emphasis here on data sharing and information collected about individual members and having those members be partners in their healthcare through that data platform allowed City Block Health to very rapidly identify who is at risk and intervene in an aggressive way to ensure that their members were well taken care of at really that height of the pandemic. And again, here, thinking about those services that are beyond the direct clinical care and including things like pharmacy, mental health resources, and community resources as well. So some of the key features of partnerships that we want to emphasize is that communication and information sharing are critical to maintaining these relationships over the long term, and being creative about who those partners could be. So looking outside that traditional realm of who are our partners and thinking critically about what are those gaps that our partners can fill to help support our community in new ways. And so, Shefali, I think we wanted to spend a little time now talking about what are some of those kind of internal challenges that we want to overcome and kind of get past some of those mental roadblocks that folks sometimes face when they're working on this type of an initiative.
That's right. Yeah. You know, as we focus on and do this type of work, it can be, you know, just so rewarding, I think, professionally and personally to help individuals, you know, meet their sort of basic human rights and health needs. But, you know, we have to recognize that this really is not easy work. It's very, very hard work. And I think one of the most common challenges is that you can very likely anticipate pushback and get pushback. And so our advice, you know, to all of you is certainly just anticipate it, you know, and we want to leave you with some ideas of things that you may hear as it relates to some of that pushback and some ways to think about how to position yourselves. So on the left here, we have some examples of some of the kinds of things that we often hear in talking with our members around this type of work. One of them is, you know, this isn't our responsibility or our organization's responsibility, or we just have so much on our plate right now that we have to focus on. We don't have the capacity to take this on. Another area that we often hear is, you know, how do we take these efforts that we're doing in different ways across our organization and create scale out of them? And then the last one, which, you know, to be honest with you, is the one probably we hear the most, is show us the money, you know, demonstrate the ROI on these kinds of programs. And so, you know, we want to leave you with a few different strategies that you could think about as you anticipate this kind of pushback from others. The first is, you know, be prepared to demonstrate some quick wins, but as you're doing that, think about it in terms of setting the stage for long-term wins. Sustainability is not going to look like a single solution. It will very likely be a patchwork of multiple solutions. So use your data from your successes to identify those opportunities that you can then create scale with. And then finally, reimagine and redefine ROI. One way to do that is actually to look beyond traditional ROI metrics. And so we're going to leave you with a couple of specific examples that you can think about. When it comes to those programs that are focusing on addressing clinical manifestations, look at things like adherence to care regimens, compliance rates with taking medication, emergency department utilization, length of stay in the inpatient setting. When it comes to programs that focus on aligning social needs or data with stakeholders, look at metrics like your positive screening rates, where you're screening for specific social determinants of health needs, and your closed loop referral rates, where you're actually making the connection to a CBO and then getting that information back that the patient actually utilized those services. And for community-wide anchor types of strategies, consider public health metrics that are outside of your organization as a gauge. Look at things like food insecurity rates, homelessness rates, poverty rates in your area, and see if you've been able to turn the dial on those as a result of your efforts. And most importantly, you know, keep the hype alive, right? So don't revert back to the status quo. I think, you know, it's important to realize that social disparities have been around for a really long time, and they're not going to miraculously go away. And despite all of the despair that our country has experienced over the last year, we're at a very critical defining point. The imperative to address these inequities are getting the attention of many influencers and leaders across the country in a variety of industries, not just healthcare. So take this opportunity to look within yourself, change your mindset, use empathy like Carol described, and encourage others around you that you work with to do the same. And then finally, challenge yourself, right? These topics create a lot of discomfort, and we encourage you to let yourself sit with that discomfort and feel it. If we can approach these challenges with an open mind and an open heart, we can effectively face those challenges together and all the uncertainties that lie ahead. So, you know, we want to make sure we leave a couple minutes for questions. So as we wrap up, we hope that, you know, we've given you a little more inspiration to continue all of this great work, and we hope that you are able to take a few nuggets of information and insights that Carol and I have shared back to your own work to advance what you're doing. So as we mentioned, here are some resources that we're going to be leaving you with. You'll find links to that information in the materials from today's call. And again, Ayla and the Beckers team, thank you so much for giving Carol and me the opportunity to present to your audience. I'll turn it back over to you, Ayla, and if we have time, we'd love to take a few questions.
Thank you so much, Shefali and Carol, for that great presentation today. We will now begin today's question and answer session. So you can submit any questions you have by typing them into the Q&A chat box on your webinar console. And we'll go ahead and get started with the first question that came through. Shefali, I know you mentioned some of these metrics during the presentation, but the first question that came through was just, this person wants to know, what were some of the outcome metrics and measures used to track improvement across the address, align, and anchor examples?
Yeah, so I had given some examples of some of the kinds of metrics that you could use. So, you know, really, again, I think when it comes to some of the clinical manifestations, really taking perhaps a very specific chronic condition and looking at metrics that may be tied to that. So, for example, if you have a condition where you know you're going to have individuals frequent the ED, take a look at things like high utilizers of the ED and see if you can turn the dial back on the utilization efforts as a result of some of the partnerships and work that you may be doing to address those specific needs. And, you know, that idea really kind of tends to align and apply to the other metrics as well in the address and the anchor types of categories. So hopefully that, coupled with some of the examples that I shared earlier, will give you a starting point. Carol, is there anything you'd want to add to that?
No, I think you've covered it really well, Shefali.
Thank you so much, Shefali, for going over those metrics and providing some more detail on those as well. We'll go ahead. It looks like we have time for at least a few more questions, so we'll go ahead and jump in with the next one. And this person is wanting to know, what are the sources of data that you or your clients find valuable that append the social risks to the clinical data?
I think it's a really great question. We do see that there is some variability market to market about what data is available. And so we certainly encourage first looking to your public health department to see if there are data sets available there that can be useful to pair with some of your clinical data. We also know there are several publicly available resources across the country as a whole that we would encourage folks to look at, and we can share some of those in the resources for follow-up. We also, I think, really want to emphasize that it's important to look local here, and I think one of the kind of overlooked, but in a quantitative way, but is really critically important for health systems to consider is, what is that information and voice on the ground? So how do we incorporate the voices of our community members directly into these types of initiatives and leverage the critical information that they have to share? So I think working with your community-based organizations to see any data that they have available to share that can help you marry some of those clinical insights that you may be getting from your own internal data sets with the needs specifically in the community will be the most valuable analyses that you can do. And certainly taking that opportunity to talk and even survey the local community to understand better what they perceive their needs to be. I think that's also can be very eye-opening for health organizations as they look at that clinical data, pairing it with some real-time insight from the community members themselves. So I would encourage looking to the community itself and those local community partners first, and then certainly leveraging those kind of more traditional data sources from public health departments and other kind of national entities as a supplement to that.
Thank you so much for all the great advice today. And that is all the time that we have for questions. But I want to once again thank Shefali and Carol for the excellent presentation, and also thank Vizient for sponsoring today's webinar. Thank you for joining us today, and we hope you have a wonderful afternoon.